Assalamu alaikum. Welcome to this series of lectures on the gynecological track. I'm Dr. Valérie Dubé. I'm a pathologist and assistant professor at the University of Toronto in Canada, and I specialize in gynecological pathology. So I would like to thank you so much for giving me this opportunity to teach to you, and I would like to apologize for the fact that my Arabic is not good enough to allow me to teach to you in Arabic, and also for the fact that I'm cognizant I do have a strong French accent. So we'll start the series of lectures by talking about the ovulatory and menstrual cycles. And to do so, we will do a brief review of the anatomy, histology, and functions of the ovaries and uterus, and then dig into the core of the subject, which is the ovulatory and menstrual cycles, as well as their regulation by the different hormones. And finally, we'll talk about abnormal uterine bleeding and some of its causes, mainly anovulation and polycystic ovarian syndrome. Okay, so here's a cut section of an ovary. So the blood supply comes from the hilum, and the core of the ovary is composed of a stroma. The cortex of the ovary, which is the outer layer, contains multiple follicles at different stages of development. And each follicle is composed of a germ cell, which is the oocyte or the egg, as well as a middle layer of granulosa cell, and finally an outer layer of theca cells. So at birth, each ovary will contain 1 to 2 million primary follicles that each contain an oocyte. And at menarche, which is the onset of the menstruations at puberty, some of these primary follicles will start to mature during each ovulatory cycle, but only one dominant follicle will reach full maturity and release an oocyte, with the exception, of course, of the rare events where two oocytes or three could be released and give rise to multiple gestations. So the average ovary will lose 1,000 follicles during each ovulatory cycle. And this will eventually lead to the depletion of the follicles and the onset of menopause, which is the cessation of the ovulatory function. Okay, now as for the uterus. So the outside of the uterus is covered by a serosa, which is a layer of mesothelial cells or peritoneum. The wall of the uterus is the myometrium, and it's composed of smooth muscle cells, and their role is to produce uterine contractions during labor as well as during menstruation. And finally, the inside of the uterus is covered by the endometrium. The endometrium is composed of glands and stroma, and it is divided into two layers. The basalis layer is responsible for regenerating the endometrium after each period, and the functionalis layer is the layer that will change tremendously throughout the menstrual cycle and the layer that will shed during the menstruation. So now let's talk about the ovulatory and menstrual cycles. So these cycles can be approached from the ovarian point of view, which is the ovulatory cycle, or from the uterine point of view, which is the menstrual cycle. So the ovulatory cycle of the ovary is divided into two phases, the follicular phase and the luteal phase, and these two phases are divided by the event of the ovulation. The follicular phase initiates the cycle with hormonal signals that will stimulate the growth of the follicle and its maturation. And after the ovulation, the luteal phase is characterized by the formation of a corpus luteum. And if ever pregnancy does not occur, that corpus luteum will degenerate and the menstruations will begin. From the point of view of the uterus, the menstrual cycle represents the changes within the endometrium under the influence of the fluctuation of the hormones that are released by the ovaries throughout the ovulatory cycle. So the uterine cycle is divided into three phases. First, there's the periods or menstrual phase, the proliferative phase, and the secretory phase. So the start of the period signals day 1 of the menstrual cycle. When fertilization does not occur, as we said, there's a drop in hormones and there is a shedding of the functional layer of the endometrium that is called menstruation. Towards the end of the periods, the proliferative phase will start gradually. And during the proliferative phase, the endometrium will rapidly regenerate and thicken due to the rise in estrogen levels. And the length of the proliferative phase will vary from one person to the other. Now, once ovulation occurs, then there is an elevation in progesterone level, and that will initiate the secretory phase through which the endometrium will further thicken and change to become able to welcome the implantation of the embryo. So, contrary to the proliferative phase, the normal secretory phase has a very set, fixed number of days. It lasts a fixed 14 days. Okay, so the ovulatory changes and endometrial changes, they're tightly regulated by the fluctuations of diverse hormones and feedback loops that will involve the hypothalamus, pituitary, and ovaries. And this is called the HPO axis. So what happens during the cycles with these hormones and these changes? So if we start with the follicular and proliferative phase, what happens? So first, GnRH is secreted by the hypothalamus, which will stimulate the anterior pituitary to release LH and FSH. So LH will stimulate the theca cells within the ovarian follicles, and it will stimulate them to produce androgens. And these androgens will penetrate the inner layer of the follicle, which is the granulosa layer. And under the influence of FSH, the granulosa cells will transform these estrogens into these androgens, into estrogens. The estrogens secreted by the granulosa cells will support the transformation of the immature oocyte into a mature secondary follicle, also called Graafian follicle, until the ovulation. This estrogen will also influence the endometrium and support the growth of the endometrium during the proliferative phase. Okay, so now the luteal and secretory phase, what happens? So the luteinizing hormone, LH, which was secreted by the pituitary, we said it helps to develop the follicle, but it also triggers the ovulation. And then after the ovulation, the luteal and secretory phase start, and LH stimulates the transformation of the follicle into a corpus luteum. So corpus luteum is a Latin term that means yellow body. And the reason is that the corpus luteum is very yellow in color because it has a lot of lipidic hormones as well as a yellow pigment that is called lutein. Okay, so the corpus luteum will produce progesterone, which will induce the changes, the secretory changes within the endometrium and prepare it for implantation of the embryo and support the early pregnancy. And as we said, if fertilization does not occur, that corpus luteum eventually degenerates, which will lead to decline in progesterone and trigger the breakdown of the endometrium and the start of the periods. Okay, here's a summary of all the hormones involved and their specific role. This slide is just as a referral for you, just additional information. It's a different way to look at things. Okay, so we said that throughout the cycle, the appearance of the endometrium will change tremendously, and mainly it's the functionalis layer of the endometrium that will change. Okay, this fact can be used by pathologists to provide a dating of the endometrium on endometrial biopsy. So mainly that can be useful for patients with infertility. So the gynecologist can do an endometrial biopsy, will look at it, and will look at the appearance of the glands and the stroma of the endometrium and try to figure out at which day within the cycle that patient is. And the main goal is to try to detect, is this endometrium secretory, within the secretory phase, which means that the patient did ovulate, which is very important information for patients with infertility. It is not a perfect tool, but it can be useful. Okay, so now we talked about the normal menstrual cycle and normal onset of breakdown and bleeding. Um, But many patients, what they will experience is abnormal uterine bleeding outside of a normal cyclic menstrual phase. Abnormal uterine bleeding is defined as any bleeding that is irregular, excessive, or prolonged compared to a woman's usual menstrual pattern. So, what are the causes of abnormal uterine bleeding? There's an acronym that can be very useful. It's called PALM-Cohen acronym. And that it characterizes some causes of the abnormal uterine bleeding. So the PALM portion of the acronym includes mostly structural abnormalities, and these can be measured by imaging or histopathology, and they include causes that usually are best treated with surgical intervention. So, for example, polyps, adenomyosis, leiomyoma, and malignancies. The Cohen portion of the acronym represents non-structural etiologies for abnormal bleeding, and they are usually better managed medically. So these include problems with coagulation, diverse problems of the endometrium, for example, endometritis, other types of infections. Um, Iatrogenic causes, so an IUD can give some abnormal bleeding, but also oral medications such as medications for epilepsy, antidepressants, and so on. We'll focus on the abnormal bleeding caused by ovarian dysfunction, which can include different causes. For example, anovulation, early menarche, perimenopause, premature ovarian failure, lactation. So usually, women breastfeeding will have no or decreased ovulation because of the high hormone levels. However, this is there will be occasionally some ovulation during lactation, so it is not a perfect contraceptive method. So some women can get pregnant during lactation. Other causes of abnormal uterine bleeding due to ovarian dysfunction will include many hormonal imbalance, endocrinopathy, for example, thyroid dysfunction, patients with hyperprolactinemia or pituitary disorders, for example. Okay, now we'll focus on anovulation as a cause of abnormal uterine bleeding because it's a very frequent cause. So if there is no ovulation, there will be no formation of corpus luteum, and therefore progesterone will not be produced. And this will result in the fact that there will be persistent unopposed estrogen stimulation of the endometrium, which will lead to continuous overgrowth of proliferative type endometrium without transitioning into the secretory phase. So that thick proliferative type endometrium will become unstable eventually and will be prone to irregular heavy shedding in a unpredictable way. So it can happen anytime, after a month, after 3 months, every 15 days. It can be very unpredictable. Anovulation can be physiological, for example, during lactation, as we said, or at the extremes of reproductive life. So the first 2 years after menarche, the HPO axis is not fully mature, and that can lead the young woman will usually have quite a bit of irregular bleeding due to anovulation. And finally, of course, the few cycles before the menopause, there will be months where there will be no ovulation, and that will lead to irregular, unpredictable bleeding. And finally, anovulation can be pathological. So, for example, women who have extremely low BMI, women with high stress, but the main cause of pathological anovulation is polycystic ovarian syndrome, which is the most common endocrine disorder amongst females of reproductive age worldwide. So the prevalence can range between 5 to 26%, depending on which criteria are used for diagnosis, but also because there is some regional variations. So giving its importance, we'll spend some time talking about PCOS. So, what causes PCOS? So, there is probably a very important genetic components to it because PCOS is much more frequent in patients that have a first degree relative with PCOS. So, family history is a very strong risk factor. Now, exactly what happens in a woman's body, a woman that has PCOS, it's it's a very complex and multifactorial metabolic disorders. That is, there's quite a difference of opinion regarding what's the exact mechanism, how does it start. It's kind of like the chicken and the egg problem. Um, but generally speaking, you can understand it as a disruption in ovarian production of steroid hormones with hormonal imbalance, as well as an interplay between insulin resistance and excess androgens. What we know is that these patients have an excess in LH hormone. So the ratio between LH and FSH in these patients is superior to 2. Okay, so an excess of LH will lead to an overstimulation of the ovarian theca cells, which will overproduce androgens. And these androgens will go into the bloodstream, and the peripheral fat has the ability to convert excessive androgens into estrogens. So that will also lead to excess estrogens in these patients. Now, an excess estrogen level will interfere with the follicle development through a negative feedback loop to the pituitary. And the pituitary will shut down FSH production. So not only LH is increased, but FSH is decreased, right? So which leads to, again, an increase in the LH-FSH ratio. So now if FSH is decreased, the granulosa cells of the follicles are not stimulated and the oocytes cannot mature, which will lead to anovulation and infertility. Also, it will lead to the development of multiple small cysts at the surface of the ovaries, and this is known as polycystic ovaries. Okay, now what is the impact on the endometrium in patients with PCOS? So we said that their excess androgens are converted into estrogens by the peripheral fat, and this will lead to a steady and high level of estrogens. In contrast to a patient with a normal ovulatory cycle where there's a fluctuation of estrogen, these patients have a steady level of estrogen in addition to having excess estrogen. We also said that they will not ovulate. And without the formation of a corpus luteum, there will not be any formation of progesterone. And that leads to not only their level of estrogens are too high and steady, but they are not opposed by progesterone. There is no progesterone to transition the endometrium into the secretory phase. So the endometrium will remain into the proliferative phase and be constantly stimulated to grow and will become thick and overgrown, and that will disrupt the menstrual cycle. And not only that, it can also lead to endometrial neoplasia. And when we go over the diseases of the uterus, we will talk about endometrial endometrioid neoplasia and its relationship with PCOS as well. Okay, so how do patients with PCOS present in your office? So usually the patients will come complaining of irregular menstrual cycles or infertility, inability to become pregnant after more than a year, and that is due to the fact that they do not ovulate. They can also come complaining of signs of excess androgens. So, for example, male pattern baldness, increased facial hair, known as hirsutism, or being prone to acne. These patients will also have a tendency to be more obese due to the increased insulin and insulin resistance. Now, if left untreated, PCOS can produce quite a few comorbidities and complications, including diabetes, hyperlipidemia. These patients will have an increased risk of cardiovascular event because in patients that are obese, they can develop obstructive sleep apnea as well, and they can have quite a bit of depression and anxiety related to all of the complications of PCOS. They can also develop non-alcoholic fatty liver disease, which is now known as metabolic dysfunction associated steatotic liver disease. But most importantly, if these patients are not treated and managed properly, they can develop endometrioid neoplasia, so endometrial cancer. So how do we diagnose these patients? So PCOS is a clinical diagnosis, and we need two of the three following criteria. So first, we need to have an evidence of chronic anovulation or oligo ovulation, which means like very sporadic ovulation. We need to show an excess in androgens, either clinically with the clinical signs or through biochemically through the serum levels. And finally, the presence of polycystic ovaries. So how do we prove all that? Well, you can test for serum levels. You can test for the testosterone androgens. You can test for progesterone and show that they have a low level of progesterone. And then you can test for LH-FSH to show that there is an increased ratio. Very important to do a pelvic ultrasound, and that will show the presence of these small cystic follicles at the surface of the ovaries that gives it an appearance of a string of pearl. So this is a very high yield fact. On ultrasounds, patients with PCOS have a feature called string of pearls, which represent the presence of almost circumferential small cysts at the surface of the ovary. The advantage of doing an ultrasound is that it will also assess for endometrial thickness, and the possibility of an endometrial biopsy. It should be considered, especially if the endometrium is thick, or at time of diagnosis of PCOS as a baseline, to make sure that there is no endometrial hyperplasia or carcinoma. What's the best management for patients with PCOS? First, lifestyle changes that include low carb diet, exercise, weight loss. I know even a small reduction of weight loss can really improve fertility in these patients, so it is very important to advocate for that. But very importantly is that they need hormonal treatment. So important to give them combined hormonal contraceptives, which can be by pills, patch, vaginal ring, for example. The reason is that the progesterone in these contraceptives will protect against endometrial neoplasia by opposing the estrogen levels. So these hormones will also lower the LH levels through the feedback loop, which will reduce ovarian androgen production. And also some of these contraceptives on the market, their progestin have also a direct anti-androgenic property. So that can really help the women with their facial hair increase and so on. An intrauterine device that contains levonorgestrel, which is a type of progesterone. For example, Mirena is a commercial brand is very, very important because it will provide direct protection to the endometrium against endometrial neoplasia by opposing the high estrogen levels. Of course, like these hormonal treatment will only be done if there is no immediate desire for fertility, and they need to be removed if the patient wants to become pregnant. But to keep in mind is that it's very hard for these patients to become pregnant because they are anovulating. So if there is a desire for fertility, then they need usually to be referred to a fertility specialist. Also to note, you can add spironolactone to the medical treatment of these patients. So spironolactone is a diuretic, but it also has as a side effect an anti-androgenic effect, which is actually a desired side effect for patients with PCOS. So a low dose of spironolactone can be really helpful for these patients to control, the facial hair and acne and so on. Okay, so this concludes this introductory talk about the ovulatory and menstrual cycles. If you have any question, please do not hesitate to reach out to me. I have an email address just for you guys. I will go into a special inbox in my phone, which is written on the slide, Dr. Valerie Dubé Gaza at yahoo.com. Thank you.